So now we're going to begin the unit on obesity, which is a growing problem in the United States and poses a significant health risk. So this is really important, especially since many of you are going into health professions, for you to have a thorough understanding of this, because there's a lot of misinformation out there about obesity. I'm lucky because I am on the Commission on Dietetic Registration's certificate of training faculty for the certificate of training on obesity interventions for adults, and get to work with some of the leading experts in the country. So I've had an opportunity to learn from some of the best on this. So I'll share some of the things that I've learned. But first, before we go into the physiology of obesity and things like that, we need to talk about weight bias, because everybody has an experience with weight. Everyone has fat tissue, everyone has lean tissue in certain proportions in different areas. So there's no way that a human being can escape some type of experiential bias when it comes to weight and body fat. Because there's a natural tendency for people to think that others experience life the same way they do and should be able to do the things that they can. I've seen this when people say they just don't understand why people can't just, eat less and move more if they have overweight or obesity. And it's because they don't understand what's going on with that individual person, not just their psychological makeup, but their physiology. I have a confession to make. I used to take Men's Health magazine because I was into weightlifting, and it had really good articles on weightlifting. And one time I got mixed up and I got a different men's fitness journal. And one of the editors wrote this editorial on how he was in his 40s and still had ripped abs and weighed the same thing he did in his early 20s, and did not understand these men with the dad bods and all that kind of stuff. He was, he had explicit bias about people and their increasing body weight as they got older. Well, I wanted to write him and say, look, dude, not everybody's like you. First of all, not everybody is in the fitness industry, and they might not have time to do the amount of exercise you do. They might not have the same mental makeup to be as rigid about their diet and exercise as you are. And not everyone shares your physiology. They don't share your genes. So that can affect how their experience with increasing weight as they get older. So that was an example of explicit bias. He had a negative attitude toward people with overweight and obesity, and was not open to other ways of thinking. He was just sure that his experience would be just like everyone else's experience would be like him. Other explicit biases are, when people with overweight or obesity are paid less and things like that. Bullying, when people who have overweight or obesity, are called names. That's an example of explicit bias. Implicit bias is something that you need to think about, especially if you're going into a health or fitness profession. You don't really think you're biased against people with overweight or obesity, but you really are. And I've seen this in action. When people assume that people who've lost weight, are doing really well, like, oh, you look so great, you've lost weight. Well, weight loss is not necessarily a good thing. It could be an indicator of an eating disorder or some type of medical issue. I know someone who was undergoing treatment for cancer, and someone complimented her on her weight loss. And that person didn't mean anything ill by it, but, it just showed that her bias is, when you lose weight, that's always a good thing. That's a type of bias. So there is a test online, and I'll put the link on Blackboard, that you can actually take to see if you have some type of bias about overweight or obesity. And at this point, I do want to mention that we now use first-person language with overweight and obesity like we do for obesity. It's not an obese person, it's a person with obesity. It's not a diabetic, it's a person with diabetes. So that is something that you'll see more and more in the professional literature as it takes off. But we don't want to define the person as their condition. It's person-centered language. So people do make all sorts of assumptions about persons with overweight or obesity, but you cannot judge what's going on just by looking at a person. And I have some examples here. This is a little girl in South Texas. Her story was on the news a couple of years ago. And the picture on the left is, she was a lean, healthy child. And then she developed a pituitary gland tumor. So she had to have a surgery to remove the tumor from her pituitary gland. And the brain surgery that she had damaged her hypothalamus, which is part of the brain that regulates appetite. So anyway, her appetite regulation system was messed up. Her brain appetite regulation system was messed up by surgery. So this child who had never struggled with overeating all of a sudden had this insatiable desire to eat, and she became really obese. They call it hypothalamic obesity. And it's very difficult to treat. She ended up having gastric bypass, and she lost weight and then gained it back. And then she had another type of revision surgery. But her weight was getting to a point where it was impacting her health, not to mention her psychological well-being, but because of the impact on her health of this, growing obesity for her, she had to have surgery. This is another thing. I saw some stuff on this on the news. This is an actress, Ashley Judd, and she had to go on a medication for a health condition called prednisone. It's a type of steroid, and it causes weight gain. And so there's all sorts of negative press about her appearance, and sometimes the face becomes distorted, so they're accusing her of plastic surgery and all this, but it was steroid use for a medical condition. People who have certain types of cancer have to go on steroid medications, especially brain cancer, because prednisone is a powerful anti-inflammatory, and they gain a tremendous amount of weight. Okay, so I've seen people who become obese from medications that they have to use. There's a lot of psychotropic medications that also stimulate the appetite and cause weight gain. In the case of prednisone, it not only stimulates the appetite, but the steroid actually increases fat synthesis. So I have a case study on weight bias. RD is a woman. She was athletic up to her mid-20s, about 5'4" and 140 pounds, pretty lean actually, a large muscle mass. But then, in her mid-20s, she became extremely fatigued and experienced some type of lump in her throat when she swallowed. So she went to a doctor. The doctor told her she was probably pregnant, which was not possible. The doctor should have done a little bit of a check on her medical history before concluding that. But since the doctor was pregnant herself, maybe that's why she assumed pregnancy, she stayed across the room from the patient and didn't really look at her symptoms. She just kind of talked to her for a few minutes, and she ordered some blood work, thinking that RD may have hepatitis or some other cause for her fatigue. The blood came back negative. The blood work came back negative, so the doctor told her she just probably had a virus and to rest and drink a lot of fluids. Took a long time, but the lump in the throat finally went down, and RD started to feeling a little bit better, but never fully regained her energy, didn't have the energy to resume her workouts or anything like that. And she actually started drinking sugary beverages with caffeine to keep her energy up throughout the day, and started gaining weight steadily and gradually. She also noticed that she started losing her hair and was feeling really cold all the time. So years went by, the weight kept increasing. never got her energy back. She would periodically go to doctors who would tell her she was depressed because she would say she was really fatigued and, didn't really feel like doing anything and was gaining weight. They prescribed antidepressants, told her to exercise and lose weight, and she would feel better. By her mid-30s, she weighed over 225 pounds. She started having really, really heavy periods then. It's called menorrhagia. And the bleeding wouldn't stop, so she started going to doctors again. She was really anemic from the blood loss. The first doctor prescribed triple-dose birth control pills because birth control pills can help control periods, and told her that the bleeding was due to her obesity. The bleeding didn't stop, so she went to a gynecologist who prescribed several rounds of progesterone, which is a hormone, and it did stop the bleeding for the 2 weeks that she was on these courses of progesterone, but the weight always came back. And progesterone is a powerful appetite stimulation as well, so she continued to gain weight. She also went to an endocrinologist, did no blood work, just, again, told her she needed to lose weight. That was the cause of the bleeding. So the bleeding didn't stop, so the next treatment was a D&C to stop the bleeding. And her sister, who was in the waiting room when the doctor came out after the procedure was over, he said, "This just happens sometimes to large women," to the sister. So that did stop the bleeding for a couple months, but then it came back, and the gynecologist told her that if it did come back, she'd have to have a hysterectomy because of the anemia, the blood loss. But she had to move out of state for a new job, and when she got there, she went to a new doctor and told her, her medical history, that, the doctor said she'd need a hysterectomy, and he said, "Well, I'm going to do some blood work first." So he called RD 2 days later and said, "You have severe hypothyroidism that's been going on for a really long time, and that's what's behind the extreme fatigue, weight gain, and bleeding." She was 260 pounds by that point, over a course of over 10 years. Her TSH, which is a lab value that is used to diagnose thyroid disease, was 88. It was supposed to be 0.4 to 4.5. The higher the TSH, the more hypothyroid you are. So it was the highest value he'd ever seen in his practice. So he prescribed thyroid hormone replacement meds. The bleeding stopped, the periods back to normal, didn't need a hysterectomy after all. And over the next 18 months, she was 39 by this time, she had the energy to start taking care of herself. She stopped drinking the sugary caffeine beverages, throughout the day to keep her energy up. She started working out, and she lost 115 pounds. She's kept that weight loss off now for well over 15 years. So RD is me. So that's part of my story. And so the left is a picture of me when I weighed about 230. I don't have a picture of me handy at my highest. The middle was after I was diagnosed. I weighed about 220 there, so I had lost about 40 pounds from my highest. And then the right is when I was on the Oprah Winfrey Show. That was when I was 44 years old. So the weight bias of these healthcare professionals prevented a proper diagnosis of a disease for over 10 years. And it's not just the weight gain, all those years of trying to, battle weight and, feeling horrible about myself as a nutrition professor and dietitian. But it's also the damage that's done internally with undiagnosed thyroid disease. When you have hypothyroidism, your blood lipids go way up, and it increases your risk for cardiovascular disease. So, like I said before, not all weight loss is good. About a year ago, about a year and a half ago or 2 years ago, I had to change, I changed healthcare insurance with my current job at the hospital, and my new insurance didn't cover my primo-thyroid meds. So they, changed to a different medication that doesn't control my thyroid disease as well. And beginning of 2019, I noticed I was starting to lose weight without trying. And over, about 6 months, I lost 20 pounds. And that's a case where I went to my PA because I didn't feel well. I was losing hair, and I was concerned about this unintended weight loss. And, you know, the first thing she said when she opened the door to the room was, "Oh my goodness, you've lost so much weight. That's so great." I'm like, yeah, no, it's not. So this is someone, a health professional that, you know, does not have any explicit bias that I've ever witnessed about people with overweight or obesity, but she has some implicit bias that, you know, you've lost weight, so that must be good. And that's not really a healthy thing to hear, because you start thinking, what are people going to think when I start gaining the weight back? You know, when my thyroid is working like it should, well, my thyroid hormone replacement is like it should be. So not all weight loss is good. And so that's an assumption you can't make. Because I have training in eating disorders, when people lose weight, I do not comment. And sometimes, you know, when people are trying really hard to lose weight and you don't comment, you know, they're a little bit upset and they'll mention something. But the only thing I will say is, you know, you look really healthy. How do you feel? So now we can begin obesity. I'm going to stop this video and start a new one.